and there's a lot you can actually do to help these patients in terms of seeing them, also speaking to them, counseling them. Some cases you can actually treat by yourself and send the patient home. Some other cases you see to an extent and then ask advice from us. We give you advice, you can still crack on and then send him home. But there are some other cases that you see you need to call and then you admit. Some cases you just have to refer immediately. So as we go along in the teaching, we'll be able to make these distinctions. And the ENT conditions range from very simple conditions to complex and most very complicated ones. So as we run through this presentation, you'll see some terms in different colors. It's just to highlight them and to show you how important these terms are. So our first objective is actually to learn, to identify various ENT conditions, to understand the ideal approach to these various minor conditions. Some of them are major, some of them are minor. It all depends. Then to understand the basic anatomical concepts. For each section we'll be dealing with, we would look at just what the anatomy looks like, what we expect to see when you see that of a normal person, so that you'll be able to appreciate what happens when it's actually a deviation from normal. And then I was specifically asked to include the cauterization of the nasal cavity with respect to epistaxis. It's a very common presentation. And one of the things that we've also done in this area is to invite Lucy, who is here. She's a rep with the company that makes the rapid Rhino. So when I get to that point, I'll give the stage to her. She will demonstrate how rapid Rhino works and what we are going to do. So she's going to use this, and I'll also take off from there when she's done with that point. Okay. All right, so removal of ear, nasal, and foreign bodies from the ears and nose, understanding when to stop. We'll be highlighting a few of these things. And then when not to attempt. There are some things you see, once you see them, straight to ENT. Some things you see, you attempt a number of times or thereabout, and then you need to know when to stop. And then, if there are cases you see, even if you can't complete their treatment, you could be able to advise the patients and counsel them. This is what to expect, and this is what is going to happen. Peradventure, you see a case and we are not able to come right there and then to see the patient. So that is it. So we'll start with the nasal condition. So I'll just give you just a brief relevant anatomy. So if you see, that's of course that's the nasal cavity, sorry, the nasal bones that we're looking at here. This is important to understand, especially when we are dealing with people who have nasal fractures. So as we go along, you'll be able to appreciate more and more of this. Alright, so the nasal conditions were basically dealing with epistaxis, foreign bodies in the nose, nasal injury involving nasal fractures especially, and periorbital cellulitis. I'll tell you why periorbital cellulitis is very important to us in ENT. Now we'll talk about epistaxis. Of course, you can see the bleed from the nose. Sometimes patients come with a unilateral epistaxis, one side. Sometimes they come with a bilateral epistaxis. And epistaxis could range from being very mild. I'm sure most of us have had a nosebleed in the past. Some of them very mild. And before epistaxis would bring a patient to the emergency, it's pretty serious. May not be life-threatening, but it's quite serious. Because most cases of epistaxis do resolve on their own with a little bit of first aid measures, which we'll look at as we go. Just to refresh our minds of the blood supply, two main distributions: the anterior blood supply coming from the anterior ethmoids and the nasal branches of the facial artery, and then the posterior supply coming from the posterior ethmoids and the branches of the ascending pharyngeal artery. So when we talk about epistaxis, this is how the ladder goes from first aid to chemical cautery to anterior nasal packing to anterior and posterior nasal packing, and then down to surgery. So the first three points are very important to all of us, because this is something we all in this room can actually do, depending on the variety of factors, as we'll see in the presentation. So of course, you see a patient who comes into the emergency department, even though it's the minors that you're working in, the ABCDE approach is still relevant. And I must say it's important to protect yourself. Sometimes You know what could happen if an epistaxis patient should suddenly sneeze while you're standing in front of him? You have a jet spray of blood everywhere. So your first priority, protect yourself. Ideally, you should wear an apron, you should wear gloves. In some cases, you might even need to wear eye protection if you are not sure. And then, of course, the patient has to sit upright, lean forward, and breathe through the mouth, and then we'll pinch the cartilaginous part of the nose. Most times, the bleeding comes from the anterior inferior portion of the nasal septum. That's where the litus area is. So when you pinch the nose, the two alar cartilages are applying bilateral pressure on those areas. So it's actually a way of tamponading and ensuring epistaxis. Then we'll get ice packs to put in the the bridge of the nose, sometimes on the nape of the neck, because these are the areas where the blood supply, the anterior ethmoids are up here, the external carotid is down here. So we're actually targeting those vessels for a vasoconstriction that would help us. Then taking a history, very important. When did this blood start? How much of it do you think you've lost? Try to quantify. Are there features that suggest that this patient is having a symptomatic hemodynamic challenge? Is this patient feeling faint? Is he feeling dizzy? What does the blood pressure look like? What does the pulse look like? These are things that are very important when you're dealing with an epistaxis patient. And of course, the investigations. You need to secure an intravenous line and do certain investigations, including the normal baseline investigations. Then, depending on the severity of the epistaxis, a group and save might also be indicated in this patient. Okay, so just a run through of various things that can cause epistaxis. I'm sure we all know many of these things. Trauma, very important. People having fights, or maybe someone falling on his nose, dry air, irritants. Sometimes our topical medications, even our nasal sprays, could actually precipitate an epistaxis. Then a foreign body, in some cases, could also be there. Tumors, polyps, and because of tumors and polyps and things like that, it's very important for us to always try to have a look in the nose, even when we're seeing such patients. Other things like blood diseases, drugs, particularly the anticoagulants, warfarin, rivaroxaban, very, very important. And in rivaroxaban, the bleeding won't just stop, except with PAC. It takes a while for the blood, the drug to be cleared from the system. So the patient will just simply keep bleeding until we're able to stop him from bleeding. All right, so when we talk about cauterization, I'll just demonstrate something very important here with respect to cauterization. I hope I don't break this.
Just pull it.
Okay, all right, that's it. So in order to cauterize, one thing you need to understand is that, like we said, protecting yourself, having the necessary things that you need, including the silver nitrate sticks. I brought a few of them here. So this is the silver nitrate sticks. It looks like a very long matchstick. There's a silver nitrate at the end, and the silver nitrate is used to actually cauterize. So if you compare this diagram with what we're looking at here, the anterior inferior portion of the septum is usually, okay, sorry, this is actually the lateral wall of the nose. But the anterior inferior portion of the nasal septum is where most bleeds come from. So that is usually where we cauterize. That is, if that is the point of the bleed. Sometimes the bleed could come from other points, but this is the most frequent point. So, like we said, you protect yourself. We have to suction the nose, and when we see the point where the bleed is, that is where we cauterize. Now, if you see one specific point, you don't go directly to that point. We usually cauterize in a circular fashion around that point of bleed, so that we go in a concentric form and then hit the main point last, so that we cauterize the vessels that are supplying that area. Because sometimes if you go on that point, it's possible there could be a collateral somewhere that could just pop up around it. So we'll go around it and then end in the central point. Now, I noted clearly here that you don't cauterize both sides at the same time, because if you do cauterize, like I said, it's on the septum, you might cauterize so much and weaken the septum, or even in some cases cause a septal perforation if you cauterize on exactly the same time. So if it's bleeding from both sides, there's a bleeding point on one point, cauterize one side and you might need to actually pack the other side. So if you succeed in cauterizing the patient when you've seen the patient, give him Niseptine cream just to moisturize that area and then let him go home. But if you don't succeed, then of course you need to call for an ENT opinion, or you might actually need to pack the patient's nose at the next, the next step in this process. So for this point, I would like to call on Lucy to demonstrate how the rapid Rhino works, because we assume the cautery has failed and you have to pack. So Lucy.
Can I grab some water if that's okay? Ah, yeah, perfect, thank you. That's fine. Yes, thanks very much.
Awesome, thank you very much for having me in today, guys. I popped in and sort of met the team last week and just said that it's really difficult as a rep to come into A&E, and you guys are really busy, so kind of find the right person to say, I'm the rep, if you need any training, kind of come and find me. So hopefully now that I've seen a few of your faces, if you find that you've got lots of new staff and you want me to pop in at any time, please feel free to just give me a shout, that's what I'm here for. So I'll just quickly run through the putting in the model. So you guys have got a 7.5 here, is that right? Yeah. So just to let you know, we do actually have another balloon that's used for posterior epistaxis as well. I don't think it's available here, but if you at any point decide that it might be a really helpful addition, let us know. That you probably will only need a very small number on the shelf, but it's got 2 balloons, so you inflate the posterior one first and then the anterior, and the feedback that we've had is that it's really good and really easy to use, so just something to bear in mind. So when you take the Rapid Rhino, it looks like this in the packet. Like I said, you've got a 7.5. You've only got one size on the shelf, which makes it easy, so just pick that one up. Once you take it out of the packet, you just take the blue sheath off here. And then the really important step is to soak it in water for 30 seconds. So if you put it in dry, it's going to be really uncomfortable. So just soak it in water, so literally just pop it in for 30 seconds. So you'll have the patient sit down, probably, like you said, maybe lean forwards, and after you've tried your initial steps, it's a good idea just to get them to blow their nose so you can clear everything out before you insert the Rapid Rhino. And then soak it in, like I said, for 30 seconds. It's a little bit difficult with this model, but I'll hopefully try and demonstrate. Obviously you can't pull the patient's nose back. So you just want to put it in literally sort of flat. Hopefully I can get it. There we are. So when they're sat down, you're literally going to be putting it in parallel to the floor. So don't angle up, don't angle down, just parallel to the floor, straight in, and then you can see it'll sit in like that. When this is soaked in water, I don't know if you guys want to have a feel. It's really nice and lubricated. So it's covered in CMC, which is a plant-derived sort of gel, and it will stay moist for up to 72 hours. So the difference between this and Maricel, which you guys have probably seen as well, is that it stays nice and moist, so that when you insert it, it's much more comfortable for the patient. You can feel it's really slippery. There you are. So it's really much more comfortable for the patient, and also, again, when you go to remove it, it stays moist for up to 72 hours. You're probably not going to keep the Rapid Rhino in for that long. But when you go to remove it, it means that it comes out hopefully without the clots kind of adhered to it, whereas with an alternative that's a dry kind of packing, maybe you'll find that you pull it out and then you get rebleed. Obviously it can still rebleed when you remove the Rapid Rhino, but hopefully the chance is smaller. So once the patient sat down, like I said, and you sort of put it in parallel to the floor there, what we're going to do is just fill the balloon up. So you've got the 10 or 20 ml syringe, and you just pop it in here. And once you can see that this little blue ring is inside the nose, so just inside the nostril, the blue ring on the end there, you're then going to inflate. You guys can all see. Can you see that? Yeah. And you just inflate to the point with this pilot cuff here, just so that it then feels firm. So that's all you're doing, it feels firm, and it kind of, like, if you push too much air in, it will kind of give you a bit of a pushback, so you just inflate it like that. So you then take the syringe away and let the patient sit for sort of 15 or 20 minutes. Because of the CMC coating, which by the way is plant derived, so there's no contraindications, which is great. Once you've sat the patient down, because it's quite cool, it can reduce the inflammation quite quickly sometimes. So just be aware that it might start to migrate out the nose, so it's a really good idea if you can to go and check again in 15 or 20 minutes and just pump it back up again a little bit if you feel like this collar here has kind of deflated. And you just want to then tape this up on the cheek, high on the cheek, so it's the swallow guard, so that the patient can safely sit there and you're not going to have to worry about them just swallowing that, so just tape it back up there. So like I said, leave them in. I don't really know exactly what your protocol is, it changes between each hospital, but leave them in as per your protocol. Maybe you want to discharge them, by 4 hours time, or whatever it might be. And then when you're going to take it out, you literally just deflate. So you insert the syringe, you just pull the air out, and then it should come out easily, like so. Any questions?
What sort of size person can you use?
Yeah, it's always a tricky question. So you guys have only got 7.5 on the shelf, and when I spoke to some of the other doctors, they said that they find that it's always sufficient, and it's an okay size. So you're probably always going to just use a 7.5. It is our anterior and posterior balloon, so it is meant to be the more general size. And with regards to kind of patient size and anatomy, even if you've got a small patient, it could be that they've got quite a big area. So we can't really advise on
something about peds specifically.
Yeah, so if you wanted a smaller, like I said, you've only got 7.5 on the shelf. So if you wanted a smaller balloon, they're a little bit cheaper because they're smaller. We do one for peds. 7.5 we probably wouldn't generally see being used, but it seems that here it's the only one that they've got. So it's kind of up to you guys. Sam, have you got
I would
any
just add to that. I mean, I don't think peds need packing in almost every case.
No.
I think. I mean, can you recall how many you've packed, Keith?
Well, I've never.
Yeah, the reality is you don't generally, because actually almost all are going to be self-limiting unless they've got some other condition. So sometimes you get kids who've got venous dyscrasias, blood clotting problems, etc. But actually they're going to be really unusual. And I think if there are kids like that, then we ought to be involved from the outset anyway. But I think actually in most kids you can struggle with first aid.
Any other questions at all? Brilliant. Thank you very much.
Okay,
Thank you.
Thank you very much. So,
I don't know if this is helpful to leave with you guys. It's just like a poster with the directions. If there's people that obviously aren't here today,
Definitely.
and if you want some other copies, I've got lots more I can drop in. So
Please.
I'll leave that with you.
Thank you.
thank you very much.
That's all
Do you have a PDF of it, Lucy?
Yeah, I can do a PDF for you. Who is it best to send that to?
Me.
Alright, Lucy, thank you very much. We'll just keep on with the presentation. Now we'll come to something a little bit more interesting. Foreign bodies in the nose. And it could range from anything. Most times we see it in children, or we see it in adults with special needs. And it could range from anything to paper, beads, batteries, etc. Now, it's important to understand that whenever you see a unilateral discharge in a child that has persisted for days, it is a foreign body until proven otherwise. Because generally, we don't see unilateral discharge. Even if it's a flu, it doesn't always just come as a unilateral. So, when you see a smelly discharge unilaterally in a child, it's a foreign body. So, it's very important to look into the nose and also take a look. Now, in removing this, of course, definitely we have to restrain the child, and the assistant has to hold the head in place when we're trying to remove foreign body. Okay? Then good visualization is important. You need a good light source and a nasal speculum. I did bring the nasal speculum for us to see. I don't know, have we used this before? Yeah, we've used this before. So we just hold it like this. It actually opens up the nasal cavity like this and makes it wider for us to be able to see what's actually going on in there. The key thing is having a good light source and also being able to see what we're doing. Then alligator forceps, or what we call the Tilly's forceps. This is the nasal forceps that we use for the nose. If it's something that can be grasped, this forceps is very ideal. It has serrated edges that can actually hold on to a foreign body and then pull it out. Sometimes the foreign body is like a bead you might not be able to grasp it. What you need to do is actually to use something like this. Here's a Jobson Home Pro. Just go above the bead and bring it out. One thing we need to understand is that if the foreign body is far inside, it's a very tricky one, because as you can see, if a foreign body migrates backwards too much, it can actually fall into the airway. You see, the airway is just here. It can go from the nasopharynx down to the oropharynx and even into the airway. So you need to be careful. You need to weigh what is actually going on. You need to gauge the depth, how far it is, and decide on the safety associated with, taking out this foreign body. The other thing you need to also understand is that with nasal foreign bodies, if you make one attempt and it slips backwards, please stop. Don't attempt anymore. And if you have a child who is too restless, because sometimes movements of the child could inadvertently make you push it even deeper. When you have a child who is too restless and who is not really allowing you, it's a good idea to also stop at that point. And then you call the ENT. What we do is actually to book this child for, CPOD or an elective surgery, and then we'll take it out. Now, the decision as to whether it's CPOD or elective actually lies with us, but the general principle is that if it's an organic foreign body, it needs to come out as quickly as possible. If a child has a bottom battery in the nose, that must come out immediately, because the bottom battery can actually release caustic substances that cause intense mucosal erosion, and sometimes perforation of the septum can also take place. So this is just a picture of foreign body removal under general anesthesia. Yes, nasal injury. Sometimes, especially over the weekends, fights happen, things go on, people get drunk and lots of things go on. So people generally come down with nasal injury. And we see this mostly in young people, or probably in the elderly or other ages, maybe due to an accident. So we see that there's a deformity of the nose. Sometimes the nasal injury could be with a force coming anteriorly, sometimes it could be laterally. Most of them that I've seen occur laterally. So there could be swelling, there could be redness, ecchymosis around, and there could also be epistaxis in these patients. So the approach is actually to take a history, and it's important to ask if there's any clear fluid coming from the nose, or if the blood is actually looks dilute. If it's coming, then you might have an idea this might be not just epistaxis, there could also be CSF leaking. And when you have that, that should raise some alarm bells, and you need to call in the ENT immediately. And then you ask about diplopia and upward gaze. It just gives you an idea of how extensive this fracture is. Sometimes it could involve the orbit, and that's why patients might have these kind of features. Of course, note the shape of the nose, note if there's nasal obstruction, and when you examine, feel the nose. If there's a crepitus, note the change in shape. If there's an infraorbital paresthesia, feel the orbital rims, like I said, if there's any discontinuity. It's just for you to have a very clear picture of what you have. Because even when you eventually call the ENT, it's good to actually give a very strong description of what you're seeing. I talked about the septum for haematoma because that is very important. If there is a septal haematoma, it needs to be drained immediately. Many cases of nasal fractures that involve nothing more than just a deviated nasal bone has to be discussed, and then we'll book in our outpatient clinic or in the SAU to see in a few days, and then arrange for it to be reduced within 14 days. So that's actually the time limit. From injury to 14 days, the reduction has to take place somewhere along that period of time. So these are things you need to actually explain to the patient. So there's really no need for an X-ray except you are looking at medical legal reasons, or the patient has multiple extensive complex fractures, in which case a CT will actually be more helpful in that case. So like I said, if there is no complicating factor, the nose and the nose is straight, just leave it alone. If there's an orbital fracture, you have to refer immediately. If there's a septal hematoma, refer him immediately. That's a red flag. And if there's a change but no complicating factors, you refer to ENT to be seen in SAU about 5 days post-injury. Then between day 5 and day 14, we have to arrange for it to be reduced. Of course, like I said, 2 weeks to reduce to get the best chance of a good result. Now, I left septal haematoma here because when you see a patient with a nasal injury, it's important to look into the nose. Look into the nose clearly with a light. If the patient has a septal haematoma, like you can see from the picture, it will have a swelling, soft fluctuant in the nasal cavity. What this is just a bleed under the mucosa of the nasal septum. And the problem with this is that if the patient if this is not drained, it can actually get infected, lead to a necrosis, damage, extensive damage to the septal cartilage, and the patient could end up with a saddle nose, that the nose just loses its architecture and then just falls off, which is quite difficult to deal with. So we do an IND, and after doing the IND, what we do is to pack the nose just to keep the space, to obliterate the space so that it doesn't recollect, give prophylactic antibiotics. So the lesson in this case is, if you see a patient with a nasal injury, please look at the nose. If you look and you see what looks like a septal hematoma, please refer immediately. It needs to be dealt with right away.
Can I ask a quick question?
Yes.
Would there be any indication for you guys to do a reduction on the day of presentation? Or is there absolutely no need, even if it's...
Well, for now, what we don't do that because it's very painful. It actually needs some form of general anesthesia. In some cases where general anesthesia is contraindicated, on the day of surgery, we could do a local anesthesia. But for most patients, we do a general anesthesia in the anesthetic room and then do the reduction. Because if you've seen us reducing it, it's not something you would want to do in an awake patient. It will screen the whole casualty.
And orbital fractures, you said to refer.
Yeah.
Do we refer that to you or to Max Fax?
What? Well, if it's from the nose, associated with the nose, you refer to us.
Right.
We could also have a Max Fax input, ophthalmology input also. But most times, if it's de novo from a facial nasal injury, you refer to us. And then we'll take it from there. And then depending on what we find on assessment, we can involve Max Fax. If he also has mid-facial fractures associated with them, Max Fax will be involved. If there's impairment of the vision and all of that, then we'll talk about ophthalmology being involved.
So I had one the other day that I didn't realise that we could refer to ENT because I referred it to Queen Vic. He had fractured nasal bone. He wasn't sure about the mechanism. He was assaulted, but he had an orbital floor fracture that had impingement of the muscles, which ophthalmology saw them here, and then I referred to Max Fax at Queen Vic. But would you be able to deal with that here then?
So I just got in.
Sorry.
Yeah. So I'd say if there's an orbital floor, just go to Max Fax.
Right.
Because
okay.
the nasal fracture can wait. Okay.
Yeah.
It can wait for 2 weeks.
Yeah.
But the orbital floor fracture can't.
Yeah.
So and the thing is actually if the patients end up being referred to us, then actually it's actually quite difficult for us then to refer to Max Fax. And they'll often say, well, actually you can manage the epistaxis, and then they'll want to see them in the day. So it's actually, there's this sort of back and forth. And I know you guys are in the middle of it a lot of the time, because I hear from Julian quite a bit. But actually, I think in that situation it should go to Max Fax in the first instance, because we can get involved over there. We've got a team over there, so we can get involved over there if need be. The other question you asked about reduction of fractures there and then, the biggest problem nowadays, if you go sort of historically, we used to just do it in A&E. I had mine done in A&E after I broke my nose. But actually, you have to do it fairly rapidly, so you have to see patients quite quickly. And the reality is they may not have walked straight in, or they may have been waiting a little bit of time before. So probably within the first 4 hours you could do it. But the biggest issue these days is access to cocaine. Because actually cocaine, we used to have access to cocaine in A&E. It was really easy. You just put some cocaine in the nose and flick it. And that's because it's such a good vasoconstrictor. It's such a good local anaesthetic. And without access to that, actually trying to get local anaesthetic reduction is actually, as I've said, it's not a nice thing to go. So I would say actually probably wait in those instances. If you happen to be with somebody when they fracture their nose, you can just reduce it. Okay, but it's jolly painful at the time. So you'll see rugby players do it, and their friend will just flick it back into position or something. It can be done, but it should be under some good local anaesthetic.
Yeah, perfect.
All right, thank you very much, Mr. Kimberley. So the question is, does anybody know why periorbital cellulitis would be of concern to ENT? Does anybody have any idea? Anybody know why? No, because usually, as one of the complications of, sinusitis could be orbital involvement. From a periorbital cellulitis to an orbital cellulitis, orbital abscess, subperiosteal abscess, and even cavernous sinus thrombosis. So there's a spectrum. The sinusitis we see is actually, and the reason why this is so is because the sinuses surround the orbit, except at the lateral point. So we have the frontal sinus up here, anterior ethmoids here, and then the maxillary sinus down here. So anything that involves the sinuses, infection-wise, could actually spread to the orbit. So when you see a patient unilateral periorbital swelling, you should involve ENT, and this is very common in children because the ethmoids are commonly affected in children. So they turn out to be systemically unwell. There might be a history of a flu, upper respiratory tract infection, and it might be pyrectic. There's a periorbital swelling. As you can see in the picture, you see this lovely child with swelling around the eye. So this is a classical picture of what it looks like. And when you see a picture like this, just take a history and then you need to refer to ENT. Then beware of visual deterioration. Of course, if it's an older child, they can tell you that there's a problem with vision. And you need to actually ask this so that you can use this to prioritize. If vision is deteriorating, you need ophthalmology input ASAP, you need ENT input immediately. And you also ask about color vision. Usually the red color is the first to go. So once you have an idea of all these things going on, it's important to refer immediately what you see. And then when you have this information, you tell the patient this is what to expect and all of that.
Can I just ask,
Yes.
is this also referred to as preceptual cellulitis? Are they interchangeable, or is that
Well,
something different?
preceptal cellulitis usually is just most times around the upper eyelid.
Oh.
You understand? So just before the orbital septum, there is a cellulitis. Sometimes there could be, cellulitis extending around, in which case you have to ask a lot of questions, these things and anaphylaxis.